This is Health Matters, a podcast from Mayo Clinic where we discuss the latest medical advice, news, and research to help you live a happier and healthier life. My name is Kristen Meinzer. I'm a writer and journalist, and this episode, we are talking about ovarian cancer. Ovarian cancer isn't as well known as other cancers. It doesn't get all the fundraisers or charity marathons that breast cancer does. And odds are, even if you have ovaries, you probably haven't ever been screened for it. Because unlike some cancers, ovarian cancer can be tough to catch early. But the good news is, we're getting better at figuring out where it comes from and what you can do to lower your own personal risk. On this episode of Health Matters, we're talking to someone on the cutting edge of ovarian cancer treatment, Dr. Marion Curtis. She's a researcher at Mayo Clinic in Phoenix, Arizona, and her groundbreaking studies are changing the landscape of ovarian cancer therapies. Hi, Dr. Curtis. Welcome to the show.
Hi, thank you for having me. I'm excited to be here.
This is a topic that, let's be real, we don't talk about as much as other kinds of cancers. So let's start with what ovarian cancer is. I think most people would assume ovarian cancer equals cancer in the ovaries. But is there more to it than that?
Well, that's actually pretty interesting because it turns out that about 70% of what we consider high malignant potential ovarian cancer doesn't come from the ovary. It actually comes from the fallopian tube.
Interesting.
And we think that it actually metastasizes early to the ovary and builds a home there. And that's where it gets a lot of the growth factors it needs to continue growing within the peritoneal cavity.
Peritoneal cavity is not a term that most of us know. What is that cavity?
So that's your abdominal cavity. That's where your intestines are, your stomach, most of your organs are within this region within your body.
Okay, so most ovarian cancer starts in the fallopian tubes and then moves into the ovaries or other parts of this peritoneal cavity. Why isn't it just called fallopian tube cancer instead of ovarian cancer then?
The terminology is confusing. So now if they do find a tumor in the fallopian tube, they will call it a fallopian tube cancer on the official diagnosis. But we still kind of all just group it all together, the fallopian tube, the ovary, and the primary peritoneal cancer, because ultimately they're treated the same. My personal feeling is it's probably a stem cell from the endometrium that in fact is traveling up and implanting into the fallopian tube or the ovary or the peritoneum, and that's actually the initiating disease. That's my personal theory. I'm not actually working on that, though.
Oh my gosh, that's even more fascinating. Imagine that the endometrium is actually like ground zero for all of this.
I really think it is, but it's somewhat of a mystery still.
Okay. And what are some symptoms that might be signs that somebody is suffering from cancer in this area?
So they can be kind of a variety of things, and they're not very specific. You might have bloating, you might have some pain in your pelvis or your abdomen, you might have changes in your appetite, you might have changes in your urinary frequency, back pain. And so this is a major reason why patients typically are diagnosed at a later stage in disease. We typically might dismiss those types of symptoms as just something that we deal with on a normal basis. These are the type of symptoms that we might say, I'm not feeling so great today.
Because they may just feel like this is me in a typical month. So it sounds like the symptoms can be very similar to just the hormonal fluctuations that happen in a person.
Exactly.
Now, are there certain people who are more likely to get ovarian cancer or who are at higher risk for it?
The major risk for developing ovarian cancer is age. So most patients are diagnosed at the postmenopausal age, but there are people who might have certain changes in their DNA. These are changes in the BRCA1 or BRCA2 genes that do have an increased risk for breast cancers and also ovarian cancer.
Right. I remember a while back, Angelina Jolie made the news because she had the BRCA1 mutation, underwent a preventative double mastectomy, and was very open about it all with the hopes of educating the public about the risk of this mutation. But going back to the biggest factor you mentioned, age, What is it about being postmenopausal that might increase somebody's risk for ovarian cancer?
We have these types of cells within our bodies that generate new cells. We call them stem cells. So over time,
Mm,
as the stem cells are producing new cells, they're more likely to make errors. And so that's typically why we believe that epithelial type cancers like ovarian cancer develop later in life, because those accumulation of errors over a person's life tend to result in that kind of an effect.
So these types of cancers may not be developing because of menopause itself. It may just be because stem cells just are less accurate in what they're making over time.
Right, exactly.
Now, considering that people who are older are the most likely to be at risk, should younger folks be concerned?
I think it's important to incorporate genetic testing, particularly if you have a family history of breast or ovarian cancer. It's probably a good idea to talk to a physician to discuss that risk and to evaluate whether or not it would be useful for you to have genetic testing to know if you're predisposed to these types of cancers. People with genetic susceptibility markers like BRCA1 or BRCA2 mutations, if they have those mutations, their cancers typically do present earlier before menopause.
Got it. And let's talk about screening and early detection. With a lot of cancers, starting when we're young, we get pap smears or we get breast exams. What kinds of screenings are occurring for ovarian cancer for us?
So, unfortunately, we don't have good screening for ovarian cancer. There are some blood tests that can detect a protein called CA125. And
Hmm.
CA125 can be detected in patients with ovarian cancer, and it's been tested multiple times. But unfortunately, they found that they just weren't sensitive enough. But there are some cool studies going on at Mayo, in fact, where they've actually found that they could take a tampon from a woman who's menstruating and detect cancer cells on the tampon, and then potentially be able to use that as a non invasive screening method where you'd collect your tampon and send it in to the clinic, and they could then test whether or not you have evidence of cancer cells.
Oh, that's fantastic. Why do you think that's not a widespread screening method? That sounds so non invasive.
Well, it needs to be validated. It's very much in the early stages. The data is looking very exciting, but it needs a lot more development before it could be used in a widespread population.
So, in terms of non invasive screenings, AKA something where you don't have to enter the body to collect samples, we haven't found a reliable way to test for signs of ovarian cancer. What makes it so hard to detect?
Well, I think it does kind of come back to where the cancer develops, which is deep in your abdominal cavity. There's no access to the early lesion like there is with
Mm.
something like cervical cancer, where we could do a pap smear and we're actually assessing the site of where the tumor develops. And then there's no good blood test at this time that we can use for that screening.
What about ultrasound? Could that be a potential screening tool?
There's also some work being done to try to use ultrasound. The issue is really the sensitivity and also the specificity. So, what I mean by specificity is you might use that ultrasound and you might detect what looks like a mass or something. But then, in order to find out if that's actually cancer, the patient would have to undergo a biopsy. And so
Ah.
that then would be an invasive method. And there's barriers, financial barriers, time barriers to try to institute something like that. It tends to be a question of how many people do you actually have to screen with the ultrasound in order to identify a true cancer?
That makes sense. Hypothetically possible, just not practical and ultimately pretty invasive. Got it. Now, how common is ovarian cancer?
Ovarian cancer is pretty rare. Around 20,000 people are diagnosed with ovarian cancer every year. The risk of getting ovarian cancer is quite low. It's 1 in 91, roughly. And the risk of dying from it is 1 in 143.
So, just comparing the risk of getting it to the risk of dying from it, that means almost half of patients survive it then.
Yes, but those statistics actually make it one of the highest mortality cancers for people with ovaries.
So, it's not as common as other cancers, but the mortality rate for those who do have it is higher.
Yes. And that's largely due to the fact that we don't have good early screening methods.
this type of cancer ovarian cancer isn't exactly a misnomer, but it may not be capturing the full picture. A lot of cancers that happen in that general area of the body, the fallopian tubes, the ovaries, and the lining of the peritoneal cavity, look and are treated similarly, which suggests they all originate from the same stem cells gone awry. Ovarian cancer is most commonly diagnosed in people with ovaries who are a postmenopausal age. However, younger folks who have the BRCA1 or BRCA2 genetic mutations could develop it earlier in life. Many clinics now have genetic testing that people can use to help evaluate their risk. Doctors often don't catch ovarian cancer until it's pretty advanced, and that happens for two main reasons. One is we don't have a great way to screen for it. The other reason is that the symptoms are vague enough to seem like everyday ailments at first, like bloating, abdominal pain, changes in appetite, back pain, or changes in urinary frequency. It's a challenging cancer for sure. So let's talk about what we can or can't do to manage our risk. So we obviously can't control having a family history or getting older, but let's talk about things we can control when it comes to ovarian cancer. Are there any behaviors or lifestyle factors that affect our risk of developing it?
So, with ovarian cancer, it's not as clear that environmental factors, things like diets, have a dramatic effect on that risk. So, there's no clear study that says that obesity, for example, is associated with ovarian cancer. In general, having those sort of lifestyle factor risks do increase your risk of cancer overall, but there's not a direct effect with ovarian cancer as with endometrial cancer, for example.
Mm-hmm.
But things that actually reduce the risk are things like taking oral contraceptives. Just having children actually reduces your risk of ovarian cancer as well.
Hmm.
And then there are certain drugs that have been shown to associate with a reduced risk. One is metformin. So this is a drug that's typically used to treat type 2 diabetes, but it's been
Mm.
shown that people that take that drug for extended periods of time actually have a reduced risk of developing ovarian cancer as well.
Oh, fascinating. So metformin and hormonal contraceptives and being pregnant can all reduce one's risk of ovarian cancer. Is there anything that's known to increase risk?
There are some associations with the use of hormone therapy. So women
Hmm.
that after menopause start taking hormones, they can have increased risk of developing these types of cancers.
All right. So taking hormonal contraceptives decreases your risk of ovarian cancer, but hormone therapy after menopause can increase your risk. I find that so interesting considering hormone replacement therapy is very similar to hormonal contraceptives. Do we know why they have opposite effects?
So, in general, we think that things like taking oral contraceptives, having children overall is reducing the number of menstrual cycles. So it used to be the thinking that the more times you ovulate, the higher your risk of ovarian cancer is. And that actually is true. We used to think it was sort of the damage of the ovary during the ovulation that would cause inflammation, that would lead to potential ovarian cancer. The thinking now actually is that there might be a stem cell within the female reproductive tract that is the source of ovarian cancer. So either within the endometrium or somewhere in the fallopian tube. And by actually stopping those menstrual cycles, you're preventing that sort of extra growth, that extra division. And so you're giving sort of a break to the whole reproductive system that reduces the overall risk of developing these mistakes.
Hmm. Now, the HPV vaccine we know reduces cancer risk in certain reproductive organs. Are the ovaries among those organs?
So no, HPV, it's a virus that infects the cells and basically induces these mistakes in the DNA that cause cancer. But ovarian cancer doesn't appear to be influenced by that virus.
Oh, darn it. That's too bad. So, is there anything else folks can do to help manage or control their risk?
We talked a little bit about the fact that ovarian cancer actually originates in the fallopian tube and not the ovary, a majority of them. And so particular patients with BRCA1 or BRCA2 mutations can actually elect to have their fallopian tubes removed. They can undergo these risk-reducing surgeries to preserve their ovaries and take only the fallopian tubes out. And studies have shown that that actually does reduce your risk of developing ovarian cancer. With my second pregnancy, I was undergoing a C-section, and I asked for them to take my fallopian tubes out. But at that time, it had not become as prevalent. But nowadays, if you're having some other sort of pelvic surgery, it is something that you can elect to have done.
Fascinating. Does that completely eliminate one's risk of developing ovarian cancer?
It dramatically reduces it.
Oh, that's great. Now, let's talk more about diagnosis. You said that screening tends to be not so straightforward, but when people are diagnosed, then how is it discovered?
Typically, it's diagnosed at a late stage. So patients will start to have some of these vague symptoms that we talked about earlier. And eventually, they become a little overwhelming to the point where someone would seek help from a physician.
Is there a certain progression level that most people are at with the cancer by the time they realize that, oh, these symptoms really are a problem?
Unfortunately, usually when it gets to that point, the patient will already have metastatic disease within the abdomen or the peritoneal cavity. Once patients come in with metastatic disease and they have very overt symptoms, that's typically called stage 3 or stage 4 disease. That's the most common time when patients will be diagnosed. But if we do catch it early in a stage 1, those women can be completely cured of cancer.
For people who have had ovarian cancer who want to have children, are they able to do that?
So typically, we're talking about women who are postmenopausal anyway and would not be having children at that point. And again, this depends on the stage of the cancer. If it was caught very, very early, then you might still have your ovaries preserved if you're younger. And then you could still go on to fertility treatment. But in a late stage presentation, it would be very difficult to try to preserve fertility.
And what is the typical outlook then for an ovarian cancer diagnosis? If somebody is caught at stage 3 or stage 4, is there a huge variance? What is the outcome for 3 versus 4 and so on?
So right now, stage 3 or stage 4 is pretty similar in the outlook. So the 5-year survival rate hovers around 30% for women who are diagnosed at a late stage. And that actually, compared to other types of cancer, something like brain cancer, that's better. The 5-year survival rate in brain cancer is something like less than 10% of patients. So with ovarian cancer, the outlook is a little bit better, but it's still pretty poor.
We know there's an unfortunate trend of people assigned female at birth not being believed or taken seriously when they raise medical issues. And given the vagueness of ovarian cancer symptoms, it feels like a lot of people could end up in a situation where they mention symptoms early on, but their doctor doesn't recognize how serious it is. Do you have any advice on how patients can advocate for themselves if something feels off and they're not being taken seriously?
I definitely think that is a big issue for sure. Because it's such a rare cancer, most primary care doctors would never have to diagnose it. And I've actually heard that from advocates. The advocates knew that there was something wrong, and their gynecologist or their primary care doctor would not accept that. So if you are getting pushback from a primary care doctor, my advice would be to get that second opinion from a specialist in the gynecologic oncology field who really knows the disease, and preferably at an academic center where more of these cases are seen.
There's not a clear link between ovarian cancer and lifestyle factors like diet, but we do know of some things that can reduce ovarian cancer risk. Taking hormonal contraceptives, having children, and certain drugs like metformin. The theory behind some of these factors is that the fewer menstrual cycles a person has, the lower their ovarian cancer risk. Another more extreme way to reduce risk is for a person to have their fallopian tubes removed. Obviously, this is an invasive surgery, but it could be a good option for people with genetic mutations that put them at higher risk. Because ovarian cancer is so hard to catch early, most people aren't diagnosed until stages 3 or 4 when their symptoms become hard to ignore. The 5-year survival rate at these stages is about 30%, which is better than some cancers, but not great overall. So, how do we improve that outlook? Dr. Curtis and other researchers are studying new ways to detect and treat ovarian cancer. So, let's take some time to dream of a brighter future for cancer treatment. Let's talk about something more hopeful. Let's talk about treatments and research, shall we? What does treatment for ovarian cancer patients look like?
On the bright side, people have been surviving longer. So the survival rate has gotten better over the past several decades. So we are doing better in treating patients. The standard treatment, though, really hasn't changed. It's the same today as 40 years ago. And that looks like surgery and a chemotherapy combination. So patients now typically, if they have advanced stage disease, may come in and they'll start with the chemotherapy, which reduces the tumor. And then that allows the surgery to be a little bit less complicated and a little bit easier. Because when people undergo surgery for ovarian cancer, if we remove as much of the tumor as we can, the patient will do better long term.
And when you're talking surgery, are you talking just removing a cancerous mass, or are you talking about removing several organs? What exactly is usually involved in surgery?
So, usually you're focused on the tumor, but there are cases where the tumor might have infiltrated into the spleen or into the colon, and that may cause additional complications that need to be addressed in surgery. But you're mostly focused on the tumor region, so the ovaries, the fallopian tubes, as well as the omentum, is adipose tissue that typically is also removed during these operations.
So, very likely a person would have their fallopian tubes, their ovaries, and other tissue removed as part of the surgery.
Yes.
And after that treatment, after the chemotherapy, after the surgery, what does life look like after that?
It can vary, but for the typical patient, ovarian cancer tends to be pretty sensitive to these treatments that we just talked about. And so patients typically do go into remission following these therapies. 1, 2 years is very common. Unfortunately, it doesn't typically stay in remission long term. So we talked about CA-125, this blood marker earlier. So a person that comes in with stage 3 disease will have a very high CA-125 number. After the initial treatment, that number will go very low. And then it is a good marker then to track recurrence of the disease. So that's one of the things that will be tracked in a person with cancer following treatment, so that when that number starts to tick up, that likely indicates recurrence of the disease.
So, the patient will continue to be tracked regularly after the chemotherapy and the surgery.
Yes.
And then, if there's a recurrence, then what happens?
Well, it depends on the individual at that point. So if the patient had stayed in remission for a significant amount of time, 1 or 2 years, that might indicate that the tumor is chemosensitive and it could be retreated with the same therapy. Or if it recurred within 6 months, which does occur in a smaller percentage of people, then we know that that cancer is not chemosensitive. It didn't respond to the treatment, and then we need to try something else. And unfortunately, in the chemo resistant setting, there aren't a lot of great options, which is where my lab and other labs were trying really to focus on this population of people that don't have other options following this initial treatment.
Let's talk about some of the research you are doing. You're on the front lines. What are you focusing on most right now as far as prevention, treatment, or managing ovarian cancer? What are you trying to solve?
In particular, we're very interested in trying to boost the immune response against ovarian cancer. And so we have a couple different things I'd like to talk about. One is an immunotherapy trial where we're enrolling women who have this resistant disease. And what we are using is sort of new technology that allows us to take the blood from patients, and then we can activate the T cells. T cells are sort of our killer cells that are able to seek out the cancer. And so using actually the patient's blood, which is, a non-invasive way for us to collect this vital source that allows us to activate the T cells in a cell therapy lab. We grow them for a period of 19 days, and then we can reinfuse those T cells back into patients to go and find the tumor and hopefully kill it.
Wow. So you know how to build an army of T cells with people's own blood and have that army do the work for you. That's fantastic.
Yeah, we're very excited about it. It's a therapy that was developed solely here at Mayo Clinic and has gone from bench all the way now to bedside.
That sounds almost sci-fi. What does this mean for patients? Does it mean that they don't have to eventually go through second rounds of chemo?
Well, we hope that will be the outcome. The amazing thing about building these army of T cells is that they have memory. So if they are able to find and destroy the tumors, a lot of them will sort of die off, and that's what we expect in a normal situation. But there will be some that are able to persist and hang around the patient long term. And so if that cancer were to ever come back, then we have those memory cells that are still in the patient and still can then go rebuild the army and go fight the cancer.
Wow. And is there any possibility that this could be applied to other types of cancer or other diseases as well?
So we think so. It targets a protein called MUC1, MUC1, and it's present in a lot of different cancers. It's present in breast cancer, it's present in pancreas cancer. So we do think that there are other options for us to expand to other cancer types.
That would be great. What are your hopes for the future of ovarian cancer treatment?
We hope that we will be able to intercept it at an earlier stage. And so we hope that something like a cancer vaccine, for example, something that can target a cancer before or prevent even the development of cancer, will have great benefit for ovarian cancer patients. I personally believe a therapy that's able to activate the immune system is the best way to go to create durable responses for patients and really have the biggest effect on long-term survival.
So the body can do the work for us without as many outside interventions.
I think so. We just have to figure out the right way to do it.
Ugh, what a dream come true. And are there other things you've uncovered in your research that give you hope?
Another study just was recently published, and what we found were that there's a unique type of tumor antigen that's present in ovarian cancers that had not been well characterized before. And so we think that we can make our immunotherapies or other therapies more effective by having a better understanding of what these antigens are. And so now what we're moving forward towards is a clinical trial based on this new sort of type of antigen where we can vaccinate patients with these antigens and hopefully keep or prevent the recurrence of the disease over time.
Oh, wow. So this is a part of a tumor that just wasn't detected before, that researchers weren't seeing. So you've detected these molecules, these antigens, and there could be eventually a vaccine to fight tumors because of this discovery.
Yeah, that's what we're hoping for.
You are like a detective. It must be so fun, so much of your job, like going through the bits and pieces and finding this and this, and this molecule does this, and yes, the butler did do it in the uterus.
Exactly.
Thank you so much, Dr. Curtis. We really appreciate it.
Thank you. It was great.
Over the years, the standard treatment for ovarian cancer hasn't changed much: chemo and surgery. However, it is becoming more effective. After treatment, it's common for a patient to go into remission for 1 to 2 years, though some more aggressive cancers can come back sooner. But there's hope. Dr. Curtis and her fellow researchers have made promising breakthroughs, especially when it comes to harder-to-treat forms of ovarian cancer. For example, they can use a sample of the patient's own blood to create an army of cancer-fighting T cells. These cells can be reinfused into the patient's blood to fight their disease and maybe even prevent it from reoccurring. Another discovery is a new type of antigen that could eventually lead to a vaccine to help fight ovarian cancer. And whether or not you yourself have ovaries, hopefully these discoveries have given you a little hope for friends, for loved ones, or even for future generations. Okay, that's all for this episode. But if you've got a question, a topic suggestion, or a follow-up question about this episode, you can leave us a voicemail at 507-538-6272. We might even feature your voice on the show. And stay tuned for the next episode of Health Matters, Nicotine Dependency.
If tobacco didn't contain nicotine, nobody would smoke. Doesn't smell good, doesn't taste good. This wouldn't be a pleasurable activity. Why would you breathe in smoke?
For more Health Matters episodes and resources, head to mayoclinic.org/Health Matters. And if you found this show helpful, please subscribe and make sure to rate and review us in your podcast app. It really does help others find the show. Thanks for listening, and until next time, take care and stay healthy.